So, welcome to Theta Rounds. I'm very pleased today to introduce Jean Yong, MSc, who I have known for probably 10 years, something like that, Jean is, I have no information here, so I'm totally free associating it. It is quite possible I will say something that is categorically false, but Jean will correct me. I think you are an engineer by training, is this correct?
That's true. I have 2 engineering degrees.
Okay, excellent. And she somehow managed to migrate into the world of health modeling. She worked with Jeff Hodge at the pharmacoeconomics unit at Cancer Care Ontario for a good number of years and built some very sophisticated and advanced and cool models in that unit. And then somehow, in the interim, has managed to migrate over to the Canadian Partnership Against Cancer, where I think she is part of or leads the OncoSim team.
I'm part of the team.
Part of the team, okay. So for those of you who don't know, I guess you'll hear about it today. OncoSim is a really interesting population-based screening platform. There are a number of these very large-scale modeling tools in the US, and various other places. This is probably the closest thing that we have in Canada to a population-based policy model for anything, never mind cancer. So I am looking forward to hearing Jean tell us about what's happening. And she has asked to do something we haven't done at Theta Rounds for a while, which is to ask people to introduce themselves. So we just say one word about who you are. And so Murray Cron, I'm the director of Theta.
Ida, I'm the admin assistant here.
I'm Eva, a research associate here.
I'm Leticia, I'm an exchange PhD student.
I'm Katarina, I'm doing my master's and doing my practicum at 6 Kids.
I'm Sam Sansit from the General Hospital.
I'm Jimbo, clinical research manager.
Paulo, biostatistician here.
Marina, PhD student.
Karen, research associate.
Brian, I'm a postdoc at Toronto Rehab.
Chris Charlie, PhD student at Theta.
Callie, I'm a summer research student.
I'm actually a PhD student. Yes.
Rosie Bain, I'm now at Theta. Came from the University of Toronto Dalalana School of Public Health.
David, I'm a project coordinator at Sickets.
Petrus, I'm a scientist at Sickets.
Charles Wright, past chair of OTAC.
Great, thank you. First of all, I'm sorry that I'm late, and I have this lame excuse of my bike chain fell off, but I'm really, really fortunate and grateful to be invited to speak here and talk to you about OncoSim. So Murray, he's brilliant. He didn't read anything about me, and he somehow got all the facts correct about me. It's true, I'm an engineer by training, and I actually did my master's in operations research, and that's where a lot of the modeling technique in health came from. My master's was on discrete event simulation, which is what microsimulation is. And then since then, I went on to work in outcomes research, which I did a lot of work preparing health technology assessments and lit reviews on burden of illness and cost-effectiveness analysis and budget impact analysis to support drug reimbursements for industry. Then I went to work for the decision makers, where I worked for Dr. Jeffrey Hodge, that I worked closely with the cancer drug decision makers on critiquing all the submissions coming to them. From there, I started a consulting group making models for people to look at different types of interventions beyond drugs. And then I was like, okay, I'm done building lots of models. I want to do something different. I spent a year in a product startup, infectious disease product startup, with a group of tech developers and designers managing a product. Then I wanted to bring all my experience together, like microsimulation, health technology assessment, and product management. That's how I got to OncoSim, because it is not just a model, it's actually a tool. You actually would think about it like a product, except it's not really like your Airbnb. It's a lot more sophisticated than just matching people to get rooms. It's about helping decision makers plan resources in cancer, especially in early detection of cancer. This one. Can I use the mouse? So to begin, I would like to say that OncoSim is a product that is led and supported by the Canadian Partnership Against Cancer, and a lot of the work is actually done by a team at Statistics Canada, their health modeling group, and that team is, they specialize in microsimulation. So in addition to OncoSim, they also work on the POEM model, which is where OncoSim came from, and all of this is through the funding by Health Canada. And in terms of conflict of interest, I'm a consultant for the Canadian Partnership Against Cancer. Therefore, the presentation might make OncoSim look really amazing, but I will try to be more critical, but a lot of those things are not listed on the slides to protect my job. And disclaimer, what I'm expressing here really doesn't represent the view of the organization. So first off, just to restate what OncoSim is a free tool. It's a web-based simulation tool. You do not need to install any software on your computer. Everything is run on the web. That's what we call web application, just like Airbnb. And it's built to evaluate cancer control strategies. Cancer control strategy is a really broad term. So anyone who has seen OncoSim before will realize that it's a very complicated model because it was built to do many things. But as the years go by, we are better at understanding what it's really good at doing, and now we are trying to improve on that. And right now, it projects health and economic outcomes for 32 different cancers, and it attributes them to 27 risk factors. And when I talk about risk factors, I'm talking about environmental risk factors like virus, smoking, physical inactivity, and that has a stronger prevention focus, which very few people in health technology assessment works on. And although it projects 32 different cancers, really there are 4 disease sites that it spends a lot of time working on, which are breast, colorectal, lung, and cervical cancers. And in terms of data, as much as possible, like the data represent the Canadian population. So the incidence data all came from the Canadian Cancer Registry whenever it's available. And when the data is not available, we work with specific province to get the data to supplement it. And if those data are not available, then we get data from administrative database and screening programs. And then a lot of the effectiveness data comes from clinical trials, which is not just Canadian. And we work very closely with like clinical experts across Canada to make sure that that represents what's going on in Canada. And the really unique thing about OncoSim is the users can go in and actually modify the inputs and assumptions to answer their questions. That's what no model does, even the CISNET models in the US, because those models, you have to work through the groups to work on those models. And in terms of insights, is really what it projects. So like some examples, like number eligible for screening, number of screening tests, number of biopsies, cancer incidence, mortality costs, life years, quality adjusted life years. So all these allow people to do population-based like resource impact analysis, or you can also call them budget impact analysis and cost effectiveness analysis. And sometimes policymakers, they just want to have some numbers, like they want to look at like incidence of certain cancer in a certain year and attribute them to risk factors. So that's more than just cost effectiveness analysis. And a little bit about what OncoSim is. So far, more than 10,000 scenarios have been run in OncoSim, and we have worked with more than 20 institutions, agencies, and networks across Canada. And there are lots of partners that come together to build this. This is not just a tool, it's actually an initiative. And it has generated more than 50 reports or papers or outputs that are used in technical briefs. And sometimes the technical briefs goes directly to the ministers. And those work are not usually published. And this is just a map showing you where our users are. And a lot of them are in cancer agencies because they are the ones who do cancer screening planning. And some of them goes directly to the Ministry of Health. And we work with a lot of groups, and THETA is listed here. So this is a history of OncoSim. The development started in 2008, and the two models that we started were lung cancer and colorectal cancer that we released the first version in 2009, 2010. Then in 2013, we released the first version of our cervical cancer model. And 2018, which was last year, that we released the first version of our breast cancer model and what we call all cancers model, which projects 32 different cancers. And that's a very prevention-focused model. And so this is just a snapshot of like some new and upcoming updates. So the unique thing about OncoSim is that you think about it like a product. It's like your Microsoft Office, and we push one version out, then we constantly work on it because we know that it's not perfect. Then we improve some input, then we push the next version out. And with every version, we release new features, new capabilities, and like make the model more flexible or like include new data that comes in. So for example, lung cancer, we started in 2008, so now it's like a decade old. So since last year, we've been really busy like revising all the treatment costs and survival data using like more recent data. And a lot of the screening follow-up protocols that we modeled like 10 years ago are no longer relevant, so we have to update that module. So that's what we meant by like new release and updates.
Can I ask something?
Sorry.
Do you want us to keep the questions for the end, or can we interrupt you?
You could ask a question, yeah.
Whatever is best for you.
Yeah, I think that's fine.
Okay. You might speak about it, but can you tell us what it takes for these models to be updated? Like, is it like a team of how many people that would need to search the literature and update what? Like
the process of updating it?
Yeah.
Yeah, that's why when Mari introduced me, I'm like, I'm not the lead of OncoSim. In fact, no one actually leads OncoSim because it's a product. It has a whole team of people, and there's different working groups, and people specialize in different things. So someone like me, who is a health economist by training, so I'm the person who review a lot of the literature on like effectiveness or performance of tests and costs for the models. And then we have a whole group of people who specialize in screening. So they know the screening technology and the data like inside out, and they would be the people who update data related to screening. Then we have all the clinical people who come in and tell us that, hey, your treatment pathway don't make any sense, and they are the one who work on that section. So we have different people work on different parts of the model. And then we have Natalie, she's the manager, and she's like in a product world, we'll call her a product manager because she makes all the decisions in like prioritizing like which one to work on first, and she goes and pitch to the boss to get money and like try to figure out how much we can do in this year versus next year. And then we have our technical team of developers who tell us what is feasible, and they tell us how to plan, how to update these models in the most efficient way. Yeah. And this is just like high-level overview of how OncoSim's outputs have been used. And the top 3 were the Canadian Cancer Statistics reports. So these are, I'm not sure if anyone of you have seen these reports. That's where you go and like pull numbers on like, what's 2017 incidence by stage or something like that. And sometimes they have special focus theme, and that's when, for example, in 2018, they look at normal call rates in breast cancer screening. So we did analysis for that. So, and like, there are 2 clinical guidelines that use OncoSim for lung cancer screening and for colorectal cancer screening. And Alberta did a report about lung cancer screening for their province. And the 3 reports at the bottom are the cancer system performance. So that's where the analysts use OncoSims to project, like, this is the current state of where we are for some of the system indicators, and the future state of what if we can do this, what if we can do that. It's like more like call to action. And here's a more in-depth example of the latest cancer system performance of like 5 analyses we did for this particular report. The first one was right now the Canadian HPV vaccination rate is about 67%, and like across the world, people are really thinking about eradicating cervical cancer. So they're like, how about what if we can reach 90%? So these are like hypothetical numbers, and it's more like a call to action to bring people who work in the clinical area together, and a lot of work on smoking. So now I'm going to go into like a little bit, give you a bit of a flavor of an independent model. So at the high level, this is OncoSim, like all cancers. It projects like 32 different cancers. And this picture is an example of a poster we'll be presenting at the upcoming ARC conference that we projected the cancer burden attributable to the top 2 risk factors, which are active smoking and physical inactivity. So these numbers, like 55,000 new cancer cases in 2018, like these are important numbers for policy decision making. Then, so this is our cervical cancer model. Really, there are 2 different models that we built. There is the interactive agent model, and then there's the OncoSim microsimulation model. OncoSim is a microsimulation model that like people don't interact with each other. But since cervical cancer is an infectious disease, we want to like introduce the infectious disease component to it without like revamping the entire microsimulation model, because we also use the same model for colorectal cancer and lung cancer. We want to keep that component simple. So what we did was we brought in another team who specializes in interactive agent model, and that team just built the HPV infectious disease part. So they model the sexual interactions and vaccination rates on HPV infections, and we passed that HPV infections across to the OncoSim microsimulation model just to simplify it. And then from after the rates passed to microsimulation model, then we model like what happens when you have HPV infection, and then it becomes, and you have abnormal cervical cancer cells, and then some of them regress and some of them actually progress to different stage of cancer. And depending on what stage of cancer people have, and then we assign treatment costs and health state utilities. That's where you do your cost effectiveness analysis.
Can you speak a little bit about how this happened? I mean, did you have to have 2 people, 2 groups, 2 teams, the OncoSim team and another team that they're working on the same language? Like is Mogen or the OncoSim language the language that's going to be used for both ends of the both models?
I'm not too sure what language the interactive agent model is built, but I can imagine you could build it in a different language, but as long as you can somehow spit out the output to go into OncoSim, like it's the integration part that we need to work on. So at the end of the slides, I'm going to share a little, this presentation, I'm going to share a little bit about like the future of OncoSim, and there's where we can talk a little bit more about language, like programming language. This is our colorectal cancer model. So it's very similar concept. It's also the natural history of the cancer. Like most people have normal and they don't have polyps, and some people have small polyps, and some people have bigger polyp, and some people have like cancer and like how they move from one to another. And once they develop cancer, then there's cost and health state utilities associated with that. And so this is a validation graph comparing OncoSim's projections with like 4 different randomized clinical trials of colorectal cancer screening. So the take-home message is like the blue dot is what OncoSim is, and all the dots are within the confidence intervals of the trials. And this is our lung cancer model. It includes, rather than a natural history of lung cancer, here we focus more on smoking behaviors and radon. And the smoking behaviors part is very complicated because instead of just looking at smoking prevalence, we simulate people, because it's a microsimulation model. Like every year there are people born in different jurisdictions, different sex. We assign attributes to them. As these individuals are born, they get older every year. And by the age 15, something special happens. Some of them will start smoking. And every year, some of them will quit smoking, or they were heavy smoker and they will become light smoker. And every few years, all these smoking behaviors will change. So for our lung cancer, because of the Canadian Partnership Against Cancer's focus in prevention, we decided to focus more on smoking. And we have a big screening module that was built using the National Lung Screening Trial, which is the pivotal trial that informed a lot of clinical guidelines. And users can use it to compare different screening strategy. And just like the other models, there is health state utilities and costs assigned once people develop cancer. And this is just a validation graph showing how OncoSim's projections compare to the National Lung Screening Trials. And OncoSim's projections, which is the blue dot, is like within the confidence intervals. And here's our breast cancer model, which is our latest disease-specific model. And it's like possibly the most complicated model, like in terms of natural history outside of cervical cancer. So it also has a very detailed screening module. And we built it based on the CISNET Wisconsin breast cancer model, which is probably their most complicated version, because there's a group of CISNET models that came together and there are many different breast cancer models. So we chose the most sophisticated one to mirror. And but all the data in our model are a Canadian model. So we copied their structure, but we calibrated our model using Canadian data. And then after all this model building is done, then we had to check if like our projection matched the trial. So this is something that we'll be presenting at the upcoming conference, that we simulated cancer screening trial in women 40 to 49, and the same thing, like OncoSim's projection is within the confidence intervals, and that's what our validation often focus on, like whether our estimates, our projections are within the confidence intervals of the trials. So, and then this is a snapshot of like all the other works that are ongoing right now using OncoSim. So in lung cancer, there's a lot of work going on in supporting the design and implementation of lung cancer screening across Canada. So EVA is doing a lot of the work. And so what happens is, like, the trials have shown that lung cancer screening could save lives, but there's like no resources in all these jurisdictions to put together like a business case to tell the administrator that this is a good idea, and if it's a good idea, how to do it. So a lot of EVA's work is really comparing different screening strategy and making sure that the analysis is specific to the province and territories. So as much as possible, we'll be using input from the province and territories and come up with output that makes sense for them. So we have like representatives from each province and territory, and they together form a working group. And so we meet together as a working group, and we meet them like independently to make sure that we produce analysis that are relevant to them. And then in breast cancer, because now there is an organized breast cancer screening programs in most jurisdictions, so we're not really talking about whether breast cancer screening is a good idea, but more that, hey, we have a breast cancer screening program, but we see like the abnormal call rate is much higher than it should be, and what should we do about it? And what happens when you have such high abnormal call rate? What happens to the downstream resources? So there is a big clinical working group focusing on abnormal call rate, and we do analysis for them projecting the impact of different abnormal call rates. And for cervical cancer, like I said, there is a global efforts for eradicating cervical cancer, so we're doing a lot of analysis on comparing different vaccination strategies and screening strategies. Also, the first vaccinated cohort of young girls are now eligible for screening. So a lot of the screening trials or studies that were done before were based on much higher HPV infection rates. So it's kind of time to like revisit some of the screening strategies. Maybe we do not need to screen these vaccinated girls the same way we screen the previous cohort. And also there is a lot of new tests coming up. And in colorectal cancer screening, there was a recent guideline on like screening family history of individuals with family history and what's the best way to screen them. So now I'm gonna pause. Like I did a lot of like marketing about what OncoSim is about. And here I'm gonna talk a little bit about why do we do that? Like why do we decide it's a good idea to build a model that you would use over and over again to answer different questions? Because most of us in this room, when we took our health technology assessment course or modeling course, we were trained to build model to answer a very specific question. But OncoSim is different in a way that it's probably a little bit too complicated than it should be. And the reason it was like that is because it was built to answer different questions. So for the Canadian partnership, they were convinced that we need these cancer simulation models because they have a very big focus on early detection and prevention, and these models are really complicated to build. And you have seen like from the CISNET group's experience, a lot of these models took several years to build. And even Canada, they recently did a cervical cancer screening HDA report, and I saw that they published that protocol in 2017 with everything was designed already, but 2 years later they published their report. So it just takes a really long time. And a lot of times when you're looking at screening, people are not always ready to do it at the same time. Like for example, like British Columbia might be ready to look at lung cancer screening, but New Brunswick, that's just not their priority right now. And maybe 2 years later, they might look into it. And for researchers, like you can't just have a model ready and like wait for someone to be interested to use your model like to answer the same question later on. And it would just take a lot of time to do that. So the partnership decided that, okay, so we're going to take this up because we're going to put some resources, and we want it to be something that people can reuse it over and over again to answer different questions, but related to cancer control. And the whole idea is to run analysis to support different jurisdictions. And that's the second point of supporting different jurisdictions is really their focus, because as we all know, there are like way more health economists that live in Toronto than in Nunavut or Northwest Territories. So a lot of the work in OncoSim, like it's my work, is supporting very small jurisdictions like Northwest Territories, PEI, New Brunswick, that they actually have no health economists there. And we would run the analysis anytime they feel like it's the right moment for them, when it's the time to brief their minister. And so the second point is the validity part and acceptance among policymakers. So these are people who don't go to SMDM. So like some kind of brand recognition really sticks with them. Like when you use something they know and like their colleagues talk about, and then they go and the screening networks clinicians talk about OncoSim. Somehow by the time it's like briefing time, they're like, oh yeah, I know OncoSim. Like everyone talks about it. rather than like just someone who does this very specific thing and show them and they're like, I don't know what this is about. This is the first time I hear about it. So some kind of brand recognition like works among policymakers, like just hearing all the different people talking about the same thing over and over again over the years. And it's not just branding, there's also the scientific part, because it was always built with this really long-term vision in mind. We spent a lot of our time validating our projections. So like other than building the model, like doing all the systematic reviews to build the model, like anytime there's new data come in, we will check our projections against new data and make sure they make sense. Or if they don't, and try to tweak our model to make sure that they reflect the latest evidence. So because of the investment in the long term, like it really makes us feel like it's like it justifies spending so much time validating our model. And like this is not just a model, and we call that web application. And what does that really mean? So you have the input like, that people can go and modify that. So how do you do that? Like it's like on the website, and how do you click on it? And how do you know that when people click on the cell, they understand what that is? Then it quickly becomes complicated, and you have to explain to people what that input is and how to change it, right? So, and you have the user interface part that you want the model to be really flexible, but you want to make sure that the user is able to like change it easily. So you have the user experience part. And the outputs, we built the model thinking that, oh, our users want the tables to be prepared a certain way. But like I said, it's a model that does many different things. So sometimes for your analysis, the output tables just don't make sense to you. And there's where we have to work with users to make sure that we revise tables that make sense for them. And then scenarios, we want it to be very useful in a way that you can create a scenario, you can save it. And we want you to feel like, hey, Jean cannot see my scenarios. I don't want her to know what I'm doing. And I don't want Murray to know that I'm actually working on this research question right now. So we have to come up with login access. And then like all the users have your special login, and all your scenarios are all just within your own account and no one else can see it. And we keep pushing out new versions all the time. And how does it work? So we have to make sure that our users have access to all the different versions and they understand what's the difference between the versions. So that's where the user support comes in. Like the model is massive. Like there are so many inputs. We have to be able to explain to our users what all the inputs are and where they came from, like what were the rationale behind picking certain inputs. So this is like a massive 500-page document that gets released with every new version. And then we have to train our users. Like we need to know why they're using the model, so we give them customized training. Then we realize that after we train them, they forget what we taught them. So we have to come up with help centers. It's just like your Airbnb FAQ, you go on and like you search and then like answers spit out so you're not writing me every day. Then we realized that, oh, those are not good enough because sometimes people accidentally like created some crazy scenario that just take the entire server down. So we have to have IT support all the time to make sure that when you take the server down, someone else running the analysis to like submit tomorrow, but yeah, poster deadline is not going to go crazy. So we have to like make sure the server comes up again like within an hour. So that's what I mean by user support. So this is what we need to build and support a web application like OncoSim. First of all, we need content experts. So that's like people like you who know a lot about modeling, a lot about clinical epidemiology and finding the right input and changing them, and the modeling people programming the models. And then we need user interface. We need to create all these places for people to click and like upload their answers and download the answers that make sense. And then we need IT infrastructure. That's like what I'm talking about, all these IT people who manage the server, pushing all the updates and making sure when Microsoft launch new updates for Internet Explorer, like our web application still integrates in the latest version. Then the user support that I'm talking about, the documentation, the help center, the demos, the training, the like answering questions all the time and like revising the model for you. And documentations for publication. When you publish your model, like the journal doesn't want to know that there is a 500-page documentation. They want a supplementary method. So like that we quickly realized that just giving more information is not the answer. Like people want to be able to like just learn about OncoSim in like 10 pages for their journal submission. Then there's the marketing. When we're busy doing all these things, we forgot that people need to know that we're still alive. That's how we missed the opportunity for the cervical cancer screening report, because we're so busy building our report, we forgot that someone needs to know that we're still alive. Then there's product management. That's where Natalie comes into place. Like she's the one who like decide what is priority right now and make sure all the things get tended to. And overall, ultimately, all these things have to go towards informing policy decisions, because millions of dollars have gone into OncoSim, and we need to make sure that it actually informs decisions. So that's how we can actually get more budget to do this. So I'm going to pause now to talk about some of the challenges we face. And just like high level, like as you can see, there are like a lot of moving parts that we need to juggle to keep this whole thing together. And it's like OncoSim is now like 11 years old. So it's time for us to pause and reflect like on all these resources that went into it, like the time and money, like what did we get out of OncoSim and how can we get more out of OncoSim? One thing we realize is we cannot do it by ourselves. Like there are things that there's just other people do way better than us. For example, the lung cancer screening, the lung cancer model, the treatment cost is 10 years old. So we're like, okay, we need to update lung cancer screening costs. And we like put everything on hold and like went and did administrative database analysis. Then got all this data back and then analyzed them. But as all of you have like experience working with admin data, like it takes a really long time. While we're like busy like messing around with the cost data, like all the other things are happening that we're missing the opportunity. So maybe that's just not going to be our thing. Maybe someone else should do that. Like we should work with someone else to work on those parts of the model. And like I said about marketing, what is marketing? It's not just us like going around like giving out brochures on the street, but it's really like people like you using the model and like putting in reports and publishing it, going to conferences. That's how people know that the model is actually active and is still alive. So that's what I mean by marketing. And then we also realized that because OncoSim was written in margin, it's a very proprietary language. In fact, it's so old that our technical vendor who builds our user interface like refused to continue to support us anymore until we decide what to do with this language. Like we chose a language that makes sense at that time. That was like 11 years ago because that was the POHM language and we used the POHM programmers. But now it's a different time. Like there's all this open source language, and why are we using a language that nobody else can do something and integrate with? Like it just makes it so static and like it's really hard to improve and collaborate. Maybe it's time we talk about like moving it to a different language. But how do we do that? Like do we just like scrap the entire thing and program everything from scratch? Maybe that's good. I don't know. Like so right now we are putting together a sustainability plan for OncoSim, and really we're going to brief out the exec and the Canadian partnership about some possible scenarios about what we're going to do, like the future of OncoSim, how it's going to look like. And if any of you have any ideas, you should come and talk to me, because maybe I'll put that into my exact recommendations. And so that's what I mean. Like we need to do this together. And some of the things that you might be able to help. So in addition to coming up with better estimates so that we can use it in the model, coming up with better costing studies so that we can plug into the model, you can use OncoSim to run analysis. You can use it as a teaching tool. For example, if you are running a workshop or you're teaching a course to teach your students how to critique model results, like how to like interpret model results, this could be a good teaching tool, because maybe you don't have, it's not within your scope of your course to teach people how to build a model from scratch, but you just want to teach them how to interpret it. So they can learn a few simple inputs, go and change something and look at and generate like 10 different scenarios and learn how to write a report based on that. So that could be a teaching tool. And you could participate in our whole initiative of comparing OncoSim's projections with emerging evidence. So for example, right now we're working with a group of researchers at the Applied Research in Cancer Control, and they are validating our cervical cancer model against new HPV screening trials. So, and if you have any ideas, then come talk to me. Thank you. Anyone have any other questions?
You know, this is a very interesting presentation and an excellent presentation, by the way.
Thank you.
I'm thinking of such a variety of potential applications here that I'm going to ask you a very basic question. When OncoSim was built, did you have any particular group in mind as users, clients? I mean, are we talking senior healthcare management people? Are we talking about clinical epidemiologists and all kinds of researchers, clinicians, oncologists? Just a question, or have you thrown it out for everybody, sort of thing?
Yeah, so that's kind of the challenge when you build a tool that answers many questions. Like, it gets too complicated, and then at some point you feel like you may not be good at doing anything because there are just too many inputs that you need to constantly update. My feeling, I wasn't part of the initial team that put this thing together. I was a little young then. And based on the people who sit in a working group that has been with the working group for a long time, they are mostly cancer screening experts. So because they have these are really famous screening trialists, because these people who sit on a working group, I have a feeling that it was always built for the purpose of early detection. And that's why we spend a lot of time on that. And I think it makes sense. You could ask, like, why do you want to spend so much money building a tool just for cancer screening? But cancer screening is a big deal because we spend millions of dollars every year just doing that. And there's a lot of things that could go wrong, and there's a lot of harms that can come from over-screening people. So, and that's why they take the few cancerous sites and screening as the focus. Some people believe that you could use OncoSim to compare treatments. I personally have not seen that happen. And the reason is that it's a little complicated to use for just evaluating treatment, because for evaluating treatment, often our time horizon is from the time that treatment starts. But in this model, because it was built by a group of screening experts, all the effects come from when cancer is detected. So it's really hard to change your relative risk estimates. So that's why we haven't really used OncoSim for evaluating treatments.
So I just wanted to add a follow-up question. So that, I mean, that's exactly my perception, that this is a tool that is designed to evaluate cancer control in a population as a whole. But of course, even in cancer, there are many questions that, so for most of us in this room are not cancer epidemiologists. We're interested in technologies, treatments of different types. And, you know, so I'm just wondering about the utility of this, like ultimately, does anyone within CPAC have the vision to have like a broader use for this? Not just treatments, but technologies. So THETA, for example, would like be very interested in the role, like, you know, PET scanning for, you know, staging for cancer, or, you know, 3 Tesla imaging for different types of cancer. I mean, there's lots of sort of technologies that are applied to cancer too. Of course, to use it in that way, it requires more than just changing parameters. You know, the model structure has to change too. So I guess what I'm wondering is if there's anyone within CPAC that has that kind of vision, that this is a cancer policy model that extends beyond just sort of population level cancer control.
So, because it cannot, we cannot make like OncoSim, like Rosie for Rosie. Like we're not making customized version of OncoSim for a specific user just for a question. We have to make sure that whatever decision we make in revamping the structure makes sense with the overarching strategy of the Canadian Partnership Against Cancer. So we just did a whole refresh of our strategy, which will be announced very soon in like the end of this month. But so far, it looks like the focus will be like what we heard from Canadians. We spoke to like 1,400 Canadians we interviewed them. A lot of people said they don't want to have cancer. They want us to help them figure out how to prevent cancer, and they want cancer to be caught earlier. Because of these input, I think it might affect how the organization decide where to spend money and what to do with the tool. Yeah. So it's a bit unique in terms of like the strategy part, like what part of the model we want to improve, because it's not run by just a group of researchers. It's like it sits within the Canadian Partnership Against Cancer. So a lot of the stuff we do have to align with the organization's priorities. Yeah.
But that was kind of my question, whether there was anyone within the institution that had that perspective, that had kind of an HTA, kind of technology assessment, health economics perspective, or is it purely about cancer control at a population level?
I think it's truly about cancer control at a population level. Like it doesn't require like a revamp of the model to do health technology assessment. They will be thrilled to have more users. But if it requires them changing the model, and that probably will not happen. The trick about OncoSim, like what I said, the tricky part is we only have a few experts who know what to do with the model. They are the only people who know the margin language. And there are so many things on the pipeline. We're constantly trying to figure out what to improve. And it's not just about money. Like no one else can join the team unless someone is willing to learn margin. So maybe if it's going to move to a different language, that might change. But right now, because we have so little programmers' time, we have to go with what is available. Yeah.
So in the pediatric space where we are, the cancer cases are not that many, thankfully, but the ones that they exist, they are screened with multiple different, there's breast cancer screening and colorectal screening and lung cancer screening on the same individual over time. Is that kind of, is that an option or a possibility with OncoSim to have the same individual sent to a, is it like a modular, is this completely modular like models, or they can talk to each other essentially, or you have the same individual go through a bunch of these different screens?
So there are two things going on. There's what happens to this simulated person. Does this person get different interventions from different cancers happening to this simulated person? Yes, it happens because like OncoSim is like an entire platform. Like one person gets simulated, this person starts screening, starts smoking, and develops lung cancer. But at the same time, because this person smokes and this person could also get like cervical cancer, like anything can happen to this same person, not just one particular cancer. So the answer is multiple things that we model in OncoSim can happen to this person. But right now, the output tables are very cancer specific because we haven't had anyone who came to us and said, hey, I'm looking at this intervention that screens people for 3 different cancers, and they're all something that you have modeled. Can you just give me output tables that look at the overall cost effectiveness, like of screening 3 different cancers at the same time? Like recently, we had a group of people that just came to us with that request, and like with more and more people like coming to us with that request, and we might think about like changing our output tables.
Sorry, I have a question from an attendee online. Abdullah Hamadi said, thank you for your presentation. Have you been able to use the software to identify the characteristics of geographical regions or specific subpopulations in which a particular cancer is common? If yes, can you then use these characteristics to better identify whom and where to screen?
So like the data itself is as much as possible broken down like at the province level. And so what happens is like we will have smoking behaviors that are different in Nunavut, like about 60% of people in Nunavut smoke versus like maybe 18 or 14% in British Columbia. So we have different characteristics depending on where this simulated person is born. It will be more likely to smoke or not. And different things will happen to this individual, but we don't use it to identify subpopulation. But we use those information to like run analysis specific for the jurisdiction. So when Nunavut comes to us and asks us to look at cost effectiveness of lung cancer screening, is using Nunavut's smoking prevalence rather than the Canadian prevalence, for example.
Thank you.
Have there been other groups that have connected with the OncoSim group to take a look at maybe producing something similar in a different disease area outside of cancer?
I'm not sure because at least not in the 2 years that I've been here. Like what I've explained here, like you can see that like a lot of millions of dollars needs to be in place for this to happen. And on top of that, it's not just about building the model. You have to have guaranteed funding going forward for X number of years to worth the effort, because just the operating cost of like keeping the servers running and having the IT support and like all these different things happening is a lot of resources. That probably explains why no other groups are doing it. Oh, yeah.
Hi. Do you know like how common it is that your predictions doesn't match your observed data? Because you have like 10,000 or I don't know, I remember how many scenarios, right? So how common it is that people have encountered that their predictions are not close to the observed data? Is it common in this OncoSim? Is it not common? It's rare?
So like because there are so many things it projects, like some of the output match and some don't. Sometimes it's the observed data's problem. Like for example, I recently projected like the amount of the number of breast cancer screens a year. Like it didn't match the data from the screening programs. And in that case, we're kind of stuck because the screening programs doesn't represent all the screening that happens, because there's a lot of opportunistic screening that happens outside the program. So our projection is more than the screening program, which is good. It's the right direction. But like, is it too much more? I don't know. So then we'll check with the Canadian Population Health Survey, because that represents like what's going on. But then that's also a survey. It's also not like the best estimate. So that's kind of the issue that we run into all the time. Like we try to validate as much as possible, but sometimes like even the observed data itself is not good enough. So all we can say is whenever we run an analysis, we track for that specific analysis, we'll validate the very important outcomes against like available observed data and just show it to the people who are reading the analysis and say, hey, look, this is where we fit. It's the truth is somewhere in between, and like when you interpret the results, you need to bear this in mind. Yeah.
It's a really interesting presentation. How do you deal with version management associated with the model, in the sense that you've had 11 years of iteration? How do you actually say, okay, this is version 1.0, this is going to be our best guess at this point in time, 10 years ago, here's version 2.0, and then do you ever go and compare what 1.0 said to what 2.0, 3.0, like how is your version management set, and then how do you analyze your improvement on the model over time?
So what we do is, like I said, we have version numbers, and with every version that we release, we have a release note. So just like your Microsoft Office, they're like, do you want to download this newest model, newest update? And they will tell you, hey, these are all the updates. You probably don't read them, but that's the kind of stuff we write. And if you are a user that you just recently ran analysis in version 3.0, and then like the next day I push out 3.1, then you might actually go and read it and say, oh, does it matter to me because of maybe the input that I'm changing doesn't matter to you because you're looking at a different question. So we have release notes that comes with every version. And sometimes when we do analysis, we're aware of the differences between versions, and we would go back, and we have a feature in the model called like import values. So we could import values from an older version and rerun the analysis in a new version, and then we'll compare the results. Like, we are not as concerned about like just a tiny difference. We're talking about like really changing the direction of the results.
Because alongside all your versions, there's been intervention on prevention screening from a public health standpoint. And so your data from 10 years ago is a reflection of the health system at the time. And your version now is being driven by interventions that are driving the actual data. So theoretically, you should be able to look at how Canada as a whole or provinces have improved in their prevention and screening rates longitudinally based on the core of your model and the data that's in it. So have you tried to do that, saying, hey, Ontario, you've done a better job over time. Here's the consequences because here's your model at 1.0 versus your model at 5.0, and here's the Ontario change, for example.
So we do project impact like that,
okay.
But we don't do it across version because the model itself, because it's a population-based model, it has a time horizon, like it has time built in it. So it starts actually in 1800s and stuff is happening. And then even when you introduce breast cancer screening, we model all the history of opportunistic screening that happens before an organized screening happens. So that's where it gets complicated because you need to model like what's going on. And so we have like all the different things happening in Ontario in 2005, then 2008, and 2010. So we projected incidents based on all the different things that are going on. So that's what we do. And we don't compare across version like that, but it achieves the same objective. Yeah. Okay. Are we?
We're at time, so thank you very much. That was like a super interesting presentation.
Thank you.
Look forward to hearing more about OncoSim maybe next year.
Yeah.